Good morning, everyone. Welcome to Grand Rounds. It looks like we have a good amount of people have shown. So I will turn this over now to Dr. Love and Dr. Bricker.
Hi, good morning, everyone. I'm Dr. Bricker. I have the distinct pleasure of introducing Dr. Stephen Love today, who's one of our fourth-year residents that will be presenting Grand Rounds. Stephen completed his undergraduate training at the University of Notre Dame and his medical training here at the University of Louisville. It has been a distinct pleasure to work with him over the last 4 years, and today he is here to talk about pluralism and psychiatry, in which he has told me he's going to present an alternative model to the biopsychosocial formulation. So I'm going to turn it over to you.
Thank you, Dr. Bricker. All right, so just a heads up, you're going to have to see the search bar at the top of my screen because otherwise I can't see my notes and it's too late to try another workaround. Anyway, I'll go ahead and start with the CME mandated disclosure slide. So I have no financial or commercial disclosures or conflicts of interest, but I do have some philosophical and perhaps mood-related disclosures, and that is that I'm viscerally unsettled by the state of our field, and even more unsettled by just how easy it is to sort of accept the flaws in our philosophy and in our current system and give in to the pressures that they create to view the field and to practice in a certain way, to the point that we forget that we made compromises to begin with, as if this is the only way it could be. So, excuse me, I'll just open up by saying that I initially intended to make my Grand Rounds a sort of magnum opus where I integrated all that I've learned thus far in some sort of novel grand unified theory of psychiatry that would describe an alternative way to approach the field. However, not only was that overly ambitious, misguided, and naive to begin with, considering I'm a novice practitioner, I still haven't even read the primary relevant text in the field, which is Jasper's. And if anything, I feel significantly less certain that I actually know what I'm doing nowadays. But it also began to seem a downright impossible task as the dawn of PGY 4-year came, and I found myself stuck in the grips of a state of something between burnout and moral injury that the previous year and a half had left me in. As such, honestly, I had a fair amount of difficulty both choosing a topic and getting myself to actually put together a coherent presentation, because pretty much everything seemed to quickly devolve into some sort of nihilistic wail that would ultimately contribute nothing productive to the conversation. But since it was personally important to me to have this presentation be something other than a defeatist cry, specifically so that I could give myself some hope as I venture out into the post-residency world come July, I decided to take a slightly different approach to this thing, which apparently required me opening up with a bit of a rant. So here are some opening points to provide some context and lay a groundwork for why this presentation came to be. And I would like to make it very clear that these are subjective opinions that I'm listing as if they're premises, but which I'm not actually taking the time to provide evidence for up front. I will freely admit that it seems a bit hypocritical for me to make such claims and present them as self-evident given the philosophical bent that I'm ultimately advocating for here. But I think the subsequent discussion of an alternative approach to psychiatry will make up for this. I also want to make it abundantly clear that I in no way, shape, or form think I actually have access to any of the answers to the uncertainties of our field. But I do believe that the sort of pluralism we will eventually discuss today is the correct path for us to take moving forward. So without further ado, we, the field of psychiatry, have lost our way, and we are only straying further from the path. Ironically, we've also developed a false sense of confidence that is only getting stronger. I believe that both of these points are true in no small part due to many of the issues related to our nosology and the fact that we like to pretend that DSM-5 is some sort of Bible of psychiatry with a bunch of scientifically valid descriptions and categories that work equally well for clinical and research purposes, as well as for insurance/billing and coding purposes, etc., when that is absolutely not the case. Further exploration of this topic is beyond the scope of this presentation. To the primary point, however, there's an even more specific reason why DSM has been so bastardized in its revisions and its application, and that is the absence of philosophy. So this false sense of confidence has a multifactorial etiology, but it seems largely rooted in our abandonment of philosophy, which inevitably leads to a self-assuredness that is downright unearned and is overtly dangerous in its effects. And by philosophy, I mostly mean, as William James once put it, an unusually stubborn effort to think clearly. So this can be seen in various places, but a general representative example, which I'll refer to many times, would be our imprecise definitions of terms leading to sloppy nosology, leading to shoddy science, leading to even shoddier real-world application of that science, leading to an overly interventional but underly helpful standard of care. Alternatively, it's possible that perhaps we do actually know that we ought not be too confident, and that we are aware that we're largely still operating within the dark, but it's simply too difficult to do things differently from both an individual and a systems-based perspective. We are additionally damned by being forced to live and to practice in a milieu that is infused with all the poison that naturally comes with late-stage capitalism, defining the necessarily for-profit rules of the game at all levels. I'd like to immediately make the point, so as to not lose any viewers, that I'm not trying to argue against capitalism, just the particular flavor of late-stage capitalism and its sequela that is seeped into all aspects of American healthcare and is perhaps the primary obstacle in the way of a more helpful and humane psychiatry, which is an intrinsically humanist endeavor that realistically is borderline impossible in our current system. And lastly, we are still plagued by ideological dogmatists of various persuasions, and the biopsychosocial model that was intended to replace such dogmatism has led to a counterproductive eclecticism that has served us no better. This has been further exacerbated by a different sort of poison that has similarly infused our milieu, and that is postmodernism. Of course, with both of these, but with postmodernism in particular, the dose makes the poison. Postmodern critiques of psychiatry, like those of Michel Foucault and Thomas Sayers, among many others, have been absolutely necessary for our reform and collective growth. However, if we're going to continue to develop our field, we need to accept these critiques where they apply and counter them where they don't. Instead of this, what we seem to have is a major portion of our field still being just as dogmatic and categorically reductionistic as in the past, albeit more quietly so, and the other major portion of the field being eclectic and relativistic with minimal clarity of views or right practices. I'll expand upon this shortly. So what should we do from here? Based off everything I just said, anything resembling a complete response to this question would be incredibly broad, and I'd be a fool to think I could personally adequately answer it, especially in this context, especially when it comes to more of the systems-based issues that are more so a reflection of our society as a whole than they are of psychiatry in particular. I have no idea what I'm doing. But now that I feel like I've sufficiently scratched the itch of the cynical soapbox rant, what I apparently had to get out of my system in order to complete the rest of this presentation, let's start over, make it simpler, more narrow, and more actionable as best we can. My primary gripes and proposed solutions are as follows. One, there is a lack of conceptual clarity in our field, specifically as it pertains to the understanding, diagnosis, and treatment of mental disorders. Two, this lack of conceptual clarity is due to an inadequate understanding and misguided application of our scientific methods. Three, the eclecticism brought about by the biopsychosocial model is no better than the biomedical or psychoanalytic dogmatism of the past. And four, in order to advance our field, we need to improve the clarity of our concepts. And five, the way to improve the clarity of our concepts is through a careful method-based approach, aka a pluralistic approach. So onto my objectives, which for the rare person who happened to watch and remember my journal club from a few years ago, will have some similar themes, and there will be a few shared slides as well, so bear with me. It's just necessary for the context. So basically, to answer the previous question of what do we do from here, what I will try to do here is briefly illustrate some flaws with our current system, discuss some reasons why they're there, and then propose an alternative approach to psychiatry that utilizes a pluralistic framework that avoids both dogmatism and eclecticism, and hopefully will also provide a better scaffolding for psychiatric understanding, as well as a bit more clarity of concepts specifically for the novice practitioners among us who might otherwise simply have his or her internal schemas be auto-populated by those of whichever attendings he or she happens to be assigned to work with the most. Since after all, the concepts that we use in psychiatry are hardly discussed in didactics or really anywhere else explicitly, though they are always present, relevant, and making themselves known indirectly in the way that we practice on a daily basis. Specifically, my objectives are as follows. Briefly describe the current state of affairs in psychiatry and illustrate how it is a logical and inevitable byproduct of our current methods. Of note, this section will be brief and is definitely not meant to be exhaustive. More specifically, describe the pitfalls of the biopsychosocial model. Describe what a pluralistic method-based approach to psychiatry would look like in general and demonstrate its utility, especially as compared to the biopsychosocial approach. And finally, expand upon one such pluralistic model in more detail, namely the perspectives approach that was first proposed by Paul McHugh and Philip Slaveny out of Johns Hopkins in their book, The Perspectives of Psychiatry. This is where the remainder of this presentation will focus, as I don't want the primary takeaway here to be, we have some issues in our field, or Stephen seems extra cynical today. Rather, I want it to be something along the lines of, this seems like a better model to use in daily practice, maybe I can give it a try, as well as a recognition of pluralism's relevance at the systems level. So I would also like to make it explicitly known at this time that pretty much everything that I'm talking about today is firmly rooted in, if not directly taken from, Nasir Gaime's The Concepts of Psychiatry and McHugh Slaveney's The Perspectives of Psychiatry, both of which themselves are strongly rooted in macro models of psychiatry that were first proposed by Carl Jaspers in his text, General Psychopathology, which was published all the way back in 1910. So, like I said, I'm going to keep this part simple and speak in relatively broad strokes with a small number of admittedly borderline cherry-picked examples. And I'm also, again, mostly going to make claims with language alone here. I suspect that this will seem inadequate to some of you considering the critiques that I'm making, and that's totally fair. However, I will refer you to the books previously mentioned, as well as to the innumerable other publications in the primary literature and elsewhere for more detailed information on these first two sections. My primary focus, like I said, is elsewhere. With that having been said, I believe that many of our primary issues revolve around an inadequate diagnostic classification system, or nosology, as well as an inappropriately wide range of its forced application. The overwhelming majority of the DSM is neither valid nor reliable, yet we all seem to just tacitly accept this while still allowing it to guide both a good chunk of our research as well as our daily practice. The DSM was always meant to be an active work in progress, but somewhere along the way, we forgot that, and we instead reified its constructs and just assumed their validity for practical purposes. Perhaps some of the older generation still keeps in mind what the DSM was really initially meant to accomplish, but I can attest firsthand that the current generation of students and residents learn about the DSM as if it is capital T true, and the negative potential impact that this has on practice, as well as on society as a whole and its understanding of mental illness, cannot be overstated. Let's take generalized anxiety disorder as an example. So GAD was split off from panic disorder during the creation of DSM-3, the latter of which, panic disorder, as an independent construct, has much more internal validity and is likely a legitimate disease primarily driven by biological factors and an understood process. However, GAD was and is far from this. In fact, it was so strongly comorbid with pretty much every other anxiety disorder, as well as MDD, that the creators of subsequent DSM revisions essentially just started arbitrarily changing things like the number of symptoms or the duration that they're required to be present until it could finally, quote, stand on its own. Now, if we look at what exactly GAD is, and we open up our minds a bit, it may very well be much better understood from a dimensional perspective rather than a categorical one, which I'll get into shortly. And perhaps it's really more of a personality trait or a predisposition to neuroticism in the general sense, rather than a disease or an illness. But that's not quite the way we see it, is it? At least not formally. Again, of course, I'm sure that many of us have much more nuance in our diagnostic schemas than the DSM alone provides, but let's not overlook the fact that A, not all of us do, B, medical students and other non-psychiatric physicians don't, C, not all other mental health professionals do, and D, the general public definitely doesn't. In addition, why must we have such unspoken nuance? Why can't we just make it explicit? Because when we don't do that, we send our patients who may just be a little bit high strung home with a label saying that they are mentally ill and a prescription to prove it. We can see the effect of this spreading in our society, especially as it seems that most of our work to, quote, destigmatize mental illness seems to have not really done anything for the people who need it most, i.e. those with severe mental illness like schizophrenia or bipolar disorder, but has mostly just lowered the threshold for individuals everywhere who might be better described and treated as if they did not have mental illness per se, but rather some sort of psychological predispositions that make life more difficult for them, or perhaps behavioral issues or a history of trauma of some sort. Of course, this is absolutely not to say that these individuals are any less deserving of empathy and understanding, nor that they aren't also within our professional purview, but rather that there needs to be some nuance and clarity to the mental illness conversation, and there isn't. As such, for example, most lay people think that bipolar illness and borderline personality disorder are essentially the same thing. This is not good for our field, and this is not good for society. Language is important, and as discussions of mental health are becoming more prominent in our society, we need to be able to speak clearly. Moving on. So much of our research is based on DSM criteria, which obviously begs the question, if our nosology isn't valid, how can the data that it leads to be valid? Again, we need only think of MDD and GAD and the innumerable studies of SRIs and psychotherapy where this one says one works and this one says the other works and a third says neither and a fourth says both, et cetera, et cetera. You would think that if we kept seeing these types of results that really don't do anything for us, we would come back to the drawing table and start to rethink the concept of GAD or major depression to begin with, or perhaps more intensely look for specific subtypes of such disorders. But of course, that's far from the norm in research, and it's nowhere to be found in practice. Next, we are increasingly seeing patients whose primary issue is that they live in a dysfunctional society and are struggling to get by. Granted, this is nothing new, but we do have reason to believe that it's getting worse. One need only look at the recent JAMA paper describing the ever-rising deaths of despair in America specifically, or the acclaimed book from 2020 about the same. Deaths of despair, in this case, meaning alcohol and drug-related deaths as well as suicides. The deaths of despair, however, are only part of the picture, as the larger relevant cohorts here are those who continue to be victims to worsening structural violence over the past half century or so. This particular bullet point could be expanded upon for the next hour, as could this general topic as a whole, that is the current state of affairs. But we'll just leave it at this for now, as it gives us more than enough to work with, and again, this is not meant to be exhaustive. The primary reason why I bring this sub-point up here is because the broader we make the definition of mental illness, the more the people whose primary issues are socioeconomic in nature get labeled as mentally ill and get treated as such, a notion which, if taken to its logical conclusion, has drastic consequences for the future of our society. After all, it is no sign of good health to be well adjusted to a profoundly sick society. The less clear we are with our concepts, the more this becomes the norm. We drive the narrative here, so it is our duty to think and to speak clearly. All right, transitioning away from that now. Excuse me. I've mentioned methods a few times thus far, so let's explore that some more. Speaking very generally, what I mean by method is basically the means by which we seek to understand and thus research, diagnose, and treat psychiatric issues. So historically, we've been ruled by two separate camps. On the one hand, the biomedical reductionists who believe that we're dealing primarily with things that we could best describe as diseases. And on the other hand, psychoanalytic practitioners who believe that we're primarily dealing with whatever exactly it was that Freud was trying to say. So the advent of DSM-3 and the adoption of the biopsychosocial model as the primary method did help to bridge this divide, which leads us to the current methods that we use. So we might be able to break this down into some independent biological, psychological, and sociological methods, though in reality, all such methods basically use the same epistemological approach, which we'll come back to. Because even though the biopsychosocial model as a single entity is technically the rule of our field, in reality, many of us are still dogmatists in practice. However, nobody wants to hear that they're dogmatists, and besides, most of us are eclectics. So to not throw too much shade and to not get too sidetracked with the epistemological nuances here, we'll call our current primary method the biopsychosocial model. So what is the biopsychosocial model and how might it be contributing to the lack of clarity in our concepts, which in turn has led to, again, sloppy nosology, which has led to sloppy research, which has led to sloppy application of such research on sloppily diagnosed patients whose outcomes ultimately often seem to be independent of what we do or don't do. Remember, this is a very complicated topic that I'm painting in the broadest of strokes for the sake of this presentation, so bear with me and know that there are lots of other resources out there that can expand upon these discussions. So what does this really mean? And more importantly, how is it currently applied? Historically, per the creator himself, it meant that all three levels, bio, psycho, and social, must be taken into account in every healthcare task. The gist is that all three levels must be given more or less equal weight as they all contributed to all medical things. And remember, this is in contrast to, say, purely viewing something as a biological disease, or purely viewing something as an issue from childhood, or purely viewing something as a reaction to social circumstances, etc. So what we think it means today is holistic care, avoidance of dogma, whether biomedical or psychodynamic or whatever, etc. That sounds nice, but what does it actually mean today? Eclecticism, anarchic eclecticism. Anybody can do whatever they want. Anybody can choose how much bio versus psycho versus social, etc., and apply it how they think it best fits to any given patient. Personalized medicine is what we might like to call it, but really it's just a system with no rules. Your counter argument may be, that's not true. I choose which to emphasize because I know what needs to be emphasized when. To that, I would say, maybe you do, probably you don't. But even if you do, then that's technically no longer the biopsychosocial model. So why are we still calling it that? And regardless, its application is inconsistent across the field and is holding us back from progress. And even worse, it's giving us the illusion of truth. While this absolutely applies on the individual level, where any given patient is potentially liable to be treated in a drastically different manner depending on which psychiatrist they happen to see, it is even more dangerous as it applies to our macro concepts, like those that go into creating our diagnostic classification system and those that guide our research and treatment guidelines. So let's take a look at it from a different perspective and see how we might be able to grasp how it could be problematic and how it might be downright inevitable that this model leads to a dangerous sort of eclecticism, both from an individual and a systems perspective. So for this, I'm going to borrow a quote and an analogy from the authors of Perspectives, first taken from their book and then referenced further by Nasir Gaimi in a separate publication. So from Perspectives, quote, "The biopsychosocial approach offers no rules, directions, or logical pathways to explain the patient groupings of DSM. In this way, the biopsychosocial concept is heuristically sterile. It denotes the ingredients, but provides no recipes to specify the use of these ingredients in explaining mental disorders." And now Gaimi expanding on this, quote, "It is not sufficient to simply know the list of ingredients. One also needs to know how much of each ingredient to use and in which order. The biopsychosocial approach only lists relevant aspects of psychiatry. It is silent as to how to understand those aspects under different conditions and in different circumstances. As a consequence, it becomes eclecticism, where the clinician essentially does whatever he or she wants to do." End quote. In a sense, it has become a shortcut to intellectual laziness. If we are not clear about our basic fundamental concepts, like what is mental illness, then how can we expect to find clarity in proper diagnosis or effective treatments? We can't. So this brings us to the crux of the primary takeaway here, which is a proposal of an alternative approach to psychiatry that avoids both the dogmatism of the past and the eclecticism of the present, and which may hopefully help to give us some clarity about what exactly it is that we're doing here. So we'll call that approach in general pluralism. As I've said several times before, this is an inherently limited conversation, and there are several different pluralistic models that one could adopt. So with that being said, briefly, we can describe this pluralistic approach as a whole as resting on three major interrelated issues that are listed here. So one, psychiatry is a unique medical discipline with disorders that emerge in personal consciousness, i.e. the domain of mind rather than a body. Two, several different classes of mental disorder exist, and these different classes deserve distinct methods for their explanation, hence pluralism. And three, less important for today, each disorder disrupts some functional feature of human mental life and thus reveals, as a kind of experiment of nature, the natural role of this feature in health. In other words, pluralism says that multiple independent methods are necessary in the understanding and treatment of mental illness. No single method is sufficient overall. And while all methods are partial or limited, they should be applied separately and purely rather than eclectically altogether. Again, this is not to say that we shouldn't consider all of the biopsychosocial factors when we're approaching a patient, nor that some patients wouldn't benefit from, say, both medication and therapy, et cetera, et cetera. It's just that we need to be more clear in our thinking and allow for pure applications where appropriate. So a pluralistic approach, including several different methods applied independently when and where they're indicated, is what we ought to replace the biopsychosocial model and its eclectic methods with. So this brings us back around to methods again. Remember, previously I stated that the current methods in psychiatry are biological, psychological, and sociological explanations, but really it's all of them eclectically combined together. A better and more complete understanding of what general methods we ought to be using, however, was elucidated nicely by Carl Jaspers, who had a lot to say on this in his original work. So framing this as an alternative to the biopsychosocial approach, where everything is thrown together haphazardly, this pluralistic approach will be much more deliberate, clear, and specific with which methods it's using, when, and why. So what's important to note here is that our methods determine the validity of our theories. Again, this is a much larger philosophical construct that dives deep into epistemology, but what I'm mostly pointing out here are some of its conclusions. Jasper says that our theories come and go with their methods, and that there are two major macro methods in psychiatry. First is the objective empiric method, aka explanation or scientific explanation. An example of this being our empiric study of the genetics surrounding the disease of schizophrenia, leading to a better explanation of the disease process. And then second is the subjective interpretive method, aka meaningful understanding. An example of this might be a psychodynamic understanding of PTSD, leading to a better understanding of the individual, though it's much deeper than this. So basically, these two methods represent overall two separate approaches to knowledge in psychiatry, both of which are independently necessary, but independently insufficient to cover everything that we encounter. We explain nature, but we understand psychic life, and we need to do both in our field. Of note, these two methods are by no means unique to psychiatry. Jaspers was just the first to consciously apply them to the field. So a classic example of objective empiric method would be in any classic, quote, hard science, like organic chemistry or physics. And then a classic example of the subjective interpretive method would be the way that we used to write history before Karl Popper's influence got to us, where, for example, the historian would write about Napoleon while trying to get into Napoleon's head and figure out what might have been going through his mind when he invaded Russia or something like that. So since our methodology determines the strengths and weaknesses of our theory, we need to be completely aware of what methods we use, what their strengths and limitations are, and why we use them or when. So basically, we ought not dogmatically approach mental illness from a single perspective, but we also ought not combine all perspectives or methods together into a big eclectic melting pot, as both extremes equally hold us back and lead us astray. So you may argue here, why not still keep the biopsychosocial model and perhaps just be more deliberate about its application, make it more consciously pluralistic, etc. The rebuttal to that, beyond the point that that's just straight up not what the biopsychosocial model is that there simply are better approaches, and that's what we'll discuss next. Of note, moving forward, as you can see on the slide here, we'll be using the terms pluralism and method-based psychiatry interchangeably, as for our purposes today, they are one and the same. So I'm going to discuss two general pluralistic approaches to psychiatry that are not terribly descriptive and are more or less saying the same things. And then I'm going to discuss a third in more detail because it's a more detailed model, and thus it might have something a bit more palpable that we can take from it today. The first example is what we'll call biological existentialism. So biological existentialism basically says some people have diseases, and when they do, those diseases can be understood reductionistically and biologically. Alternatively, some people do not have diseases. Rather, they suffer from being human beings with affliction plotted along a wide spectrum. For example, psychosocial approaches to the understanding and treatment of neurosyphilis are more or less irrelevant. They have an infectious disease, they need IV penicillin, period. Though neurosyphilis may have a complex phenomenology that can be confusing before the diagnosis is made, we always ought to pay attention to the person who has the disease above all. The disease itself can otherwise be understood in a biological reductionistic way. This approach clearly frames what we're dealing with and what the treatment approach should be. This is not the case, however, for, say, personality disorders or certain anxiety disorders. And this is an important distinction to be very clear about. As noted here, these can be split into the objective, empiric, and subjective interpretive methods of understanding and treatment. Some things are purely susceptible to the empiric approach and others are not. Same goes for the interpretive approach. So they each have their strengths and limitations. For instance, if we try to understand a disease with the subjective interpretive method, the quality of the knowledge that we obtain will be severely limited, even though we may not even realize it. Similarly, if we try to explain a person's existential struggles with the objective empiric method, we're clearly going to be missing something important. So, like I said, of course, we would still want to pay attention to the psychological and social factors influencing a person, even if they have, say, schizophrenia, neurosyphilis, or whatever. And we would certainly want to pay attention to all those things for somebody struggling with life to the point where they end up in our office. But perhaps the full appreciation of the human being in front of us would be better served by turning to the arts for a deeper understanding of the existential encounter that we're engaged in, rather than by simply using, quote, softer sciences to fill in the gaps of explanation that were left by biology. This sort of mindset leads us back to the second general example of a pluralistic model, one which perhaps we ought to have been driven by all along since it's been around forever. And that is the medical humanist method-based approach to medicine in general, as first espoused by William Osler. So the basic premise of Osler's medical humanism is that a physician's role is to treat disease in the body while attending to the human being who has the disease. There's a quote here from Guyme's Concepts that sums it up nicely. Quote, "Where disease is present, one treats the body. Where disease is ameliorable but not curable, one still treats with attention to the risks. And where no disease exists, one attends to the human being as a person. This approach has all of the strengths and none of the weaknesses of the biopsychosocial model." End quote. So this sort of humanism is individual and existential. It is not captured by another scientific discipline like psychology or sociology, merely being tacked on to the discipline of biology. And thus the biopsychosocial model does not do it justice. It is also not captured by any other single non-biological theory of medicine or psychiatry, like psychoanalysis or whatever. Rather, it is best understood by an appeal to literature and to the uniqueness of humanity and of each individual human being, which again is best approached through the arts. The biopsychosocial model does help us keep our eyes open and avoid being reductionistic when we ought not, but it also prevents us from being reductionistic when we ought. In addition, all aspects of it, the bio, psycho, and social, are inherently framed through a scientific lens, albeit with slightly different approaches and different degrees of scientific truth, which itself is a separate epistemological discussion. And this holds us back from a truly existential, humanistic conception of the personhood of whomever comes to see us, which subsequently not only interferes with our ability to truly or best understand the person/patient, but also hinders our ability to truly help them. All right, now on to the third and final example we'll be discussing, and that is what we'll call perspectivism. And this is the one that comes from the Hopkins group that I mentioned previously. So this particular approach to psychiatry, or to the psychiatric patient, requires a systematic consideration of the patient from four separate perspectives. These are the disease, dimensional, behavior, and life story perspectives. We'll go through each one of these different perspectives, explore them a bit more, and note how they represent an inherently pluralistic approach and how this would be superior to our current approaches. Mostly from the perspective of the individual working in his or her daily practice, since this is the primary focus of this particular flavor of pluralism, but also from a systems perspective with regard to how we might better organize our nosology, how we might better guide our research, and thus how we might approach treatment differently. So since this is an inherently limited discussion, I do want to make a few things clear up front. These are not mutually exclusive perspectives, and there's not always just one single perspective that is applicable in terms of diagnosis and treatment in any given case, especially considering the life story perspective is pretty much always relevant, similar to the existential focus in the previously mentioned pluralistic systems. In addition, having an issue that can be best explained by one or another perspective does not necessarily mean that the best treatment can and should exclusively be carried out within the confines of that perspective, especially since there are still so many unanswered questions and incomplete treatment approaches in psychiatry, even when it comes to the things that we know are diseases. However, there is typically a hierarchy of importance, especially when it comes to the diseases. So on to the first one, the disease perspective. So we've already discussed this a bit, but basically this is what a patient has. It can be schematized with disease reasoning, drawing connections between a clinical syndrome, a known pathological process, and a known etiology. The driving force here is that a known pathology affects the brain and exerts an effect on a patient's thoughts, feelings, and behaviors in life-altering ways. Treatment, in this case, ideally revolves around the causal link between these biological systems, and we want to try to get as close as possible to treating the actual underlying pathophysiology whenever possible, of course. So some more obvious examples here would be the dementias, delirium, and really anything that can be conceptualized with some degree of certainty as a symptom secondary to a known disease. For instance, anxiety secondary to hyperthyroidism, or psychosis secondary to autoimmune encephalitis, etc. Where things get a bit more interesting and complicated is when we start to consider more, quote, pure psychiatric issues, for lack of a better way to say it. So based off the research that we have at this point in time, we have fairly good reason to believe that schizophrenia and its likely various subtypes, bipolar illness, severe melancholic or psychotic depression, panic disorder, and some subtypes of obsessive compulsive disorder can likely be best conceptualized as diseases. So what might this mean on a larger scale? Well, if we have certain things that we know that we can best conceptualize through the disease model of reasoning, we should be doing everything in our power to approach them as such. I will grant that we obviously already do this with most neurocognitive disorders, provided we catch them, as well as to an extent with schizophrenia and bipolar illness. But I think major depressive disorder is a good example of how we're hugely missing the mark here. MDD is an almost meaninglessly heterogeneous diagnostic category that includes such a wide range of disorders that it essentially hurts us more than it helps us in both our research and our diagnosis and treatment decisions. If we know that some types of depression, as far as we can tell at this point, more severe subtypes of depression, are almost certainly legitimate diseases rather than simply reactions to life that happen to follow a somewhat consistent and similar biological end path in the brain, then why would we not try to separate these entities from those which do not seem to be diseases per se and see if we can better understand them and better treat them? For instance, there's a decent amount of data to suggest that melancholic depression is a distinct subtype of depression that responds very well to specific higher-powered pharmaceutical interventions, but very poorly to what we would call the standard of care, i.e. garden variety SRIs. If this is true, we need to be paying much closer attention to the specific phenomenology of illness that comes before us to see if we can distinguish this subtype from others, and then we need to treat it differently than we otherwise would. But we rarely, if ever, do this, because instead we see depression as depression as depression, and we treat it all more or less the same, which is absurd. But of course, how can one be blamed for doing that when very little of our research focuses on these phenomenological differences in presentations, just as very little of our treatment guidelines do? I had initially intended to go into a lot more detail on this particular subject, but I ended up triaging it out, so I'll just mention it briefly. I'm not necessarily saying here that our, quote, ideal type of depression, i.e. SIGI caps with prominent neurovegetative symptoms, is outright incorrect. Rather, it's just that it's an ideal type, and it likely includes several different things in it. Let's say we have a patient who comes to us with cough, fatigue, and shortness of breath. What's going on with them? Well, maybe it's heart failure exacerbation. Maybe it's COPD. Maybe it's pneumonia. Maybe it's a pneumothorax. The point is, unless and until we seriously look deeper and examine the phenomenology in more detail, we won't be able to distinguish between these various things. And we may end up calling all of them chest syndrome or something vague and unhelpful like that. That doesn't mean that they're all actually the same in reality. It just means we haven't distinguished between separate potential unique pathologies yet. There's more than one way to get short of air, and there's surely more than one way to get depressed. Perhaps even the route by which we get depressed matters. Perhaps that should even dictate treatment. But of course, we can't know these answers because we're not asking these questions, because all we currently have is the equivalent of chest syndrome. My point here is that if we are clear in our concepts and we take the time to distinguish between that which is a disease and that which is not, as well as between different subtypes of whatever diseases or non-disease syndromes we discover, which is likely best done through a careful phenomenological approach to distinguish between different subtypes of these disorders, then we will almost certainly be better able to understand these things and better treat them, since we'll, in theory, no longer be dealing with a vague, indistinct melting pot of various types of sadness or whatever. This would also likely have a significant social impact, since right now, the general public, as well as most of the rest of healthcare, if we're being honest, pretty much thinks that all depression is the same, and that everything that we call depression is also mental illness. And we cannot ignore the impact that that has on people. All right, so let's move on. The second perspective we'll discuss is the dimensional perspective, or what a patient is. So this can be best schematized by the cognitive and temperamental potentials or dimensions that make up one's personality, interacting with provocations or life circumstances or events, and leading to responses, which may or may not manifest as psychiatric symptoms. Cognitive dimensions include things like intelligence, and temperamental dimensions can be best thought of as the big 5 personality traits for our purposes here. So treatment is going to revolve around guiding the patient to some degree of insight into who they are and how they're wired, and then helping them to adapt accordingly, which could mean teaching techniques to manage stress when it arises, or could mean life coaching to redirect their existence into something that is perhaps more suitable for them as an individual. It could mean a million other counseling/therapy approaches in between. Speaking about this perspective in its purest sense, the best example would obviously be personality disorders or intellectual disabilities, which will best describe people that are on the extreme ends of the cognitive or temperament spectrums or dimensions. Other examples of this are somewhat easy to imagine. Basically, anytime there is a degree of stress that exceeds one's tolerance for it, for whatever reason, whether cognitive or personality related in nature, psychiatric symptoms can arise. Note that I did not say disease, I said symptoms. However, this is also a good scenario where we can clearly see that just because something is not a disease per se, it can still be managed with biological agents in a sort of supplemental approach. For example, there is plenty of evidence that SRIs decrease one's degree of neuroticism, which can potentially be very helpful to expand one's range of distress tolerance. However, we need to be explicitly clear about the fact that that's what we're doing, right? We're not treating a disease, and the patient should know that too. We are helping them manage life better, given the tools that they were born with and the circumstances that they have been thrown into. In these cases, how long should we continue SRIs? I mean, they're not depressed per se, so should our treatment guidelines be the same as those for a clear depression? Probably not. For other larger implications of this one, let's come back around to generalized anxiety disorder. As I discussed previously, GAD is a concept that was more or less artificially created with diagnostic criteria altered arbitrarily over the years until it got to the point where it wasn't comorbid with panic disorder and or MDD all of the time. Now it's just most of the time. So maybe we shouldn't be conceptualizing and discussing GAD in the same manner in which we conceptualize and discuss panic disorder or bipolar illness. Maybe GAD would be better framed as a dimensional issue. There's a reason why we all think that anxiety seems impossible to treat. That's because we're probably not dealing with some well-defined disease construct that we can suddenly make disappear, provided we find the right magic bullet for it. Like, no, we're probably dealing with a predisposition to neuroticism in the original and MMPI sense of the word that is naturally higher or lower in different individuals. And we're dealing with those individuals as they're trying to deal with life, which, as it turns out, is difficult. So if we can figure out which of our constructs can be best conceptualized as being dimensional in nature, perhaps we can start to focus our treatments on the right things. From a systems perspective, this could even help us deal with managed care a bit better, as we may be able to more rationally divvy up treatment responsibilities among a team. Also, again, we would just be much better served as a field if our nosology would distinguish between disorders that are dimensional versus disorders that are diseases. So with that being said, I'm not saying that these things are non-biological in nature or anything like that. This is not a dualistic framework. And of course, everything comes to be through biological action at the end of the day. And genetics are not exclusively relevant to the disease realm, but are relevant to our personality structures and what kinds of things we may be predisposed to be or to do, etc. But just because somebody has a biological predisposition to having high anxiety does not necessarily mean that they have a disease. Of course, maybe there actually is such a disease, ignoring the potential answer of panic disorder for the moment. Regardless, this is again something that would require a careful, descriptive psychopathology based on detailed phenomenological assessments to see if we can actually distinguish between such things. The alternative, which is what the norm is today, is simply putting all of these into one big eclectic bucket and calling it generalized anxiety disorder, multifactorial anxiety, whatever. All right. Now onto the behavior perspective. So this is obviously what a patient does. It can be best conceptualized as a series of two-way streets between physiologic drives, individual choice, and conditioned learning. Despite what we fancy 21st century monkeys want to believe about ourselves, we remain just as vulnerable to simple conditioning and learning as we did 200,000 years ago. So the driving force here is all the stuff that's involved in basic conditioned learning theory. Though the outcomes of such are not strictly the really obvious stuff, since conditioned learning can get pretty nuanced and complicated, but that discussion is beyond our scope for today. So some examples that the creators of this system would put under the umbrella of behavioral disorders are various sexual disorders, eating disorders, and various types of addiction. They also have some interesting things to say about psychosomatic and functional or conversional disorders, as well as trauma reactions like dissociative issues, which are really interesting, but too much of a sidetrack for now. And also, I'm not terribly confident in my own grasp of it yet. So basically, I think the takeaway here should be that it's not necessarily just the really obvious stuff that we think of when we think of Pavlov's dogs or rats pressing the cocaine button. And I would encourage you to explore this one on your own. So what are some potential larger implications of this being its own unique perspective? I'm going to keep this one light for a number of reasons, but I think the most interesting application that the Hopkins authors discuss in this realm is the notion that if we can clearly delineate something as a behavioral disorder above all else, then perhaps taking a pure behavioral approach to the issue would be much more effective than the sort of eclectic and holistic approaches that we currently take. In their book, they present some interesting case studies with substance use disorders as well as bulimia. This is also a good opportunity to make a specific point that's representative of something larger within this pluralistic framework, and also happens to be a huge pet peeve of mine. So as an example, if you have somebody who has an intellectual disability and they are acting out or being manipulative or whatever, then it is probably appropriate to say that they are having a behavioral issue, labeling it as behavioral, and thus to treat it behaviorally. You could also potentially frame it through the dimensional perspective, as perhaps the individual is under too much stress for them to handle, and thus they're acting out, etc. But the major point is that in this situation, neither of these perspectives is necessarily dominant. However, if you have somebody who is actively manic and they are acting out or being manipulative in the same type of way, then it is not appropriate to say that it's behavioral, because their behavior is directly related to the mania. And when the mania goes away with treatment of the disease, so does the behavior. Unless it doesn't, of course, but we rarely wait around to make that call, do we? I think one of the subtle issues of our current eclectic approach is our inability or perhaps unwillingness to make these types of distinctions. Of course, people can have behavioral issues that are independent of the issues that are directly brought about by their disease, but that is not a call you can or should make while the disease is still in its active form. And when it comes to severe diseases like active florid bipolar mania, the disease perspective should be running the show. All right, so last but not least, we have the life story perspective, or what a patient encounters. This one is obviously broad and includes all the existential stuff as well as some other things. So it can be best conceptualized as the patient encountering life circumstances that disrupt their hopes, needs, desires, goals, dreams, relationships, etc., thus leading to demoralization and distress. So treatment here in its broadest sense is going to mostly revolve around reformulating a new interpretation of events or a new, more meaningful or helpful narrative to help the patient move forward. Some more clear-cut examples, again, here are going to be things like grief, dealing with a breakup, anxiety from struggling with financial issues or other adjustment disorder stuff. Trauma could be included here, and so could adapting to having a different disease, say schizophrenia. This is the category that makes sure that we include all of the social and existential stuff that may not have come up in the other perspectives. Personally, I think the biggest impact of this particular perspective is the existential bent it kind of forces into the encounter, which I happen to believe is indispensable to effective psychiatric care. But on a larger scale, I think it helps to clarify and expand treatment options, and also may help to destigmatize large swaths of our patient population who have been otherwise pathologized for their symptoms, despite largely having more or less normal or expected reactions to the abnormal situations that life has thrown at them. This is not to say that life circumstances can't trigger a legitimate disease in somebody who is prone to such, but it is to say that this is a legitimate distinction that we need to make. All right, so that was an overview of the last example of an alternative pluralistic approach to psychiatry and to the psychiatric patient. So I did provide some more detail for that one. It was still fairly broad strokes, and there's a much richer literature to explore if anybody happens to be interested. So winding down now, with all that having been said, what are some potential barriers to implementation of an alternative pluralistic approach to psychiatry like this, both at the individual and systems level? Well, pluralism definitely requires additional effort in our thinking. The full perspectives assessment. That's why I wanted to record it. The full perspectives assessment can be very lengthy. Billing and coding requirements still trump our personal philosophies, no matter how much I want that not to be the case. DSM doesn't seem to be going anywhere, et cetera, et cetera, et cetera. And here's a short list of some flippant rebuttals to the previously listed barriers. Like, we can still do this, it just takes some effort. Anyway, to tie everything together now in a summary, psychiatry is a unique medical specialty that requires a unique set of methods to approach the acquisition and application of knowledge. This applies to the individual patient as well as to the field as a whole. Our current methods are inadequate and have led to murky foundational concepts that inevitably lead to murky research, treatment approaches, and outcomes. And the biopsychosocial model is partially to blame for this. A pluralistic method-based approach would help solve many of these problems through the clarity that it could bring to our concepts. Because if we want clarity in our work, we need clarity in our approach to it. And lastly, perspectivism is one such pluralistic approach that we could begin implementing in our daily practice today. It may be difficult to change the system, but we can always change the way that we engage with it as individuals. After all, as Dr. Seuss once said, unless someone like you cares a whole awful lot, nothing's going to get better. It's not. All right, that's all I got. I typically load these outro things, but since it is my last engagement of residency and I have the stage, I'd like to briefly take a moment to thank the department, including Dr. Casey and Dr. Caudell for lots of things, including providing me with a soapbox and a long leash, as well as specifically Dr. Al-Malik for being my primary mentor and for always being willing to engage in discussion, academic or otherwise. Dr. Frierson for showing me how to keep my humanity front and center, even if I was busy chasing zebras. Dr. Bricker for allowing me to chase zebras. Dr. Terrell for her personal and professional guidance, the independent learning opportunities she created for me in EPS, which is where I learned how to be a doctor, and for feeding me during the pandemic when my neighbors kept stealing my food. Dr. Wong for challenging me at every step of the way in all facets of my work, but specifically with my own concepts and philosophies. Dr. Clow for showing me when and how to be quiet, and Dr. Al-Malik again for showing me when and how to speak up. Dr. Goodwin for humoring me in my existential troubles and for his personal and professional guidance. Dr. Shane Bachler for never failing to make me feel like I didn't know anything. Dr. Wood for being a diaphragmatic breath of fresh air to the department. Dr. Reese and Dr. Vincent for being human beings. Christy for holding the entire department together with her bare hands. Tina for doing the same for the clinic. Martha and Martine for being my work moms. Jennifer, Jonathan, Brenda, Deidre, and all the other amazing social workers and nurses here for making all of our jobs infinitely easier. And to all the other faculty and staff who I've learned so much from the past 4 years, thank you. Lastly, special shout out, of course, to the fancy monkeys whose mere existence makes my own possible. Here are my references. That's it.
All right. Well, thank you, Stephen. We're going to open up the floor for questions. If you guys want to put your question in the Q&A at the bottom of the screen, that would be great. If you'd also like to speak in person, you can direct message either me or Dr. Reski, and we will promote you to a panelist.
All right, well, I'll go ahead and start off. Stephen has a nice presentation. It was definitely thought-provoking. I particularly appreciated the insertion of the dimensional aspect versus the on or off phenomena of what you were defining as being a disease state rather than a syndrome. I do think, though, that to a certain extent, the idea of this approach isn't something that isn't allegedly being done on a day-to-day basis. I think that this extra level of the humanistic sort of life story perspective, maybe it's a mistake that medicine does this, but it's felt to be built in as being sort of like the baseline part of being a doctor, is that you're going to look at their life story, see this person as a person, and make sure that their quality of life is the top thing that you're looking at when you're doing all of your doctor stuff. And, between the stress diathesis hypothesis and the biopsychosocial model, it does still hopefully give us a guideline to, be able to remember that we're supposed to view all these different perspectives and make sure that we're not just standing at one end of the elephant blindly thinking that it's a tree trunk. But, saying it out loud again is always helpful. In a way, I kind of regret the fact that you didn't stay on your soapbox, because there were two things that you brushed upon that I thought were very important. One is the thought of structural violence. If a rich man has grief and has a major block, then he can go see a psychotherapist and have psychodynamic psychotherapy and change his perspective. But if a poor man has his tent thrown away because it's derby time and he shows up in the ER in despair, he sometimes just gets sent home because he has meth in his system. The second part is this idea of, what's a mental illness versus what's life. And I think that, you mentioned Foucault, his book, Madness and Civilization, is a very difficult read, but it's a very worthwhile one. His point is that mental illness, we always need to have scapegoats in society. Society wants to have people that they can admonish as being the other. And it's part of our human nature, unfortunately, sociologically. And for a while it was the lepers, but now it's the madman, right? And we see this still. The stigma gets perpetuated all the time, because anytime something horrible happens and a person did it and no one can understand why that could possibly happen, the very first thing the news will say is it's unknown if they had a history of mental illness, or it is suspected that they had a history of mental illness, as if mental illness is the only thing that would cause horrible things to happen in society. But again, on the whole, a very good, thoughtful presentation. I don't actually have a question, just that comment.
Yeah, I think just to address broadly, I think one of the reasons why I come at it this strongly is because of the inconsistency. Because there's definitely, I can point to people who I know are like, yeah, I trust their approach and all this, that they're considering all these things, but I can also point to a lot who may not be the case. And I think that maybe some more concreteness to it might be helpful. I don't know. Dr. Lippman?
Yeah, the two of you both echo exactly what's happening in Congress right now. I mean, you put your finger on it with the grand rounds, and then Ben just put his finger on it with the response to violence in the schools. It's now all psychiatry. We need to fix 20% of the people that sometimes have bad thoughts, and of course not related to mental illness. And when we're, even as mental illness treaters, we're sort of all swimming in the dark. And like you said, we can't tell the difference between A and B, but we all treat it the same way. Anyway, I thought you did great. A little frustrating, a little scary to think about what's going on in Congress right now. You're going to now be responsible to discern any dangerousness in the next 25 years of every patient you see in EPS. Okay, that's all. Thank you. That was great. I enjoyed it a lot.
Yeah, I think to build off what you said, I can give this presentation, talk about like the dimension, the different perspectives, but like realistically, it's super difficult to discern between these things. It's not always that easy, which is why I always try to look for disease when I can find it, because maybe we can actually do something, but
Yeah, thank you so much, Stephen. It's always nice to hear something obviously very passionate and, the steps taken to continually improve the field. That's always, important. This is just a main observation. I actually have seen this a lot in some of my patients, particularly here at the VA, where, after a while, it's very difficult for people to understand, inherent emotions, or it almost leads to a divorcing of oneself from how you're supposed to feel in a specific situation. And I've had patients come to me where they're very confused about medications. Like, hey, I thought this was my anxiety medication. You're saying it's treating depression and anxiety. So there's not an inherent understanding. And I've just graduated to basically telling patients, well, this is mainly helping you cope. regardless of the way you respond to stress, whether it's more like the anhedonic depression, the really low and flat, or neurotic depression, the very like anxious. So it's nice to see someone kind of talking about the blending of all of these different observations and just helping people feel more informed, comfortable with, you know, how you react to things with life.
I think that's a good point. Like, I don't know, I always try to be really explicit, as explicit as I can be with patients about what the medicine is for. Like, if I think they have a disease, I make very clear, like, this is something you need to take. And otherwise I try to do like, hey, this, they take the edge off. It's not a permanent thing, you know, but.
We've got some questions in the audience. Chesico said, great presentation, really made me think. A general question, what would prevent providers from choosing which perspectives they wanted to focus on to where the approach is just as eclectic as the BPS model?
Yeah, that's a fair point. I think that the way around that would be, my argument is that the biopsychosocial model is intrinsically eclectic, whereas the perspectives has built into it the fact that there is probably going to be a hierarchy, and especially when it comes to things like diseases influencing dimensions and behaviors and stuff. So, you know, that would still be an issue, but also thinking from a broader perspective, let's say, I'm not even saying the perspectives approach is the best, it's just the most clearly detailed I could use. Let's say the perspectives approach made its way into the mainstream and that was our new BPS. If we applied that to our research, we would probably start getting more things that are like, hey, this is disease, and now we're teaching this as disease. This is dimensions, now we're going to teach this as dimensions. This is behavior, you know. So ideally, it would be a paradigm shift in the field as a whole, in the way we communicate, and thus hopefully less likely to be as eclectic.
How do you reconcile that with the existence of the DSM-5? Do you think they can coexist?
No.
And Dr. Shane Bachler put a nice quote from Emerson Pugh: if the human brain were so simple that we could understand it, we would be so simple that we couldn't. Unless there's an introspective jellyfish out there.
Octopus.
Hey, Steve, I was wondering what your thoughts are on like the multi-axial approach, like I think this stems from DSM-4, which I think kind of ties in a lot of what you're talking about, especially if we were to have more of an emphasis on axis 2. And ideally for a lot of patients, we would be able just to say for axis 1, like nothing, like they don't have an axis 1 problem. But I know that we're kind of limited as far as being required to have a diagnosis and labeling people with like adjustment disorder and that kind of thing. But yeah, do you have thoughts on the multi-axial approach? Yeah,
I think, like, on one hand, I do think we lost something with that, but I mostly think we lost something with it with the clarification of axis 1. And I think to your point, like we can't put adjustment disorder or unspecified depression for everything, right? Like I do, and I just like, you know, wait to be yelled at by somebody, but we can't do that. So as far as like, I think my issue with it was always when you throw something in axis 2, our biases start just going haywire. So as opposed to throwing something in axis 2, we could discuss it as a dimensional thing. And I think that would, at least maybe it's just less biased because it's not something we do. But that was always my concern with it.
Well, a lot of that comes back to the other bugaboo, which is the payer source, and the fact that, you know, certain medicines are only paid for certain diagnoses. Certain diagnoses can't be billed with psychotherapy, et cetera, et cetera. So, I mean, the tail definitely wags the dogs with what ICD codes are being chosen.
I think we as a field do not do a very good job of starting with what is the normal function of emotions and moods. I think every other specialty focuses on normal first, and after you learn the normal, like how the kidney functions, then you can focus on kidney disease. In psychiatry, we jump straight to mental illness without focusing on what is a normal reaction to stress or a potentially normal reaction to stress. What is expected and what isn't expected, and what is the normal function of these different sort of brain systems.
I think that's very true. And actually, I think that also shows part of my own bias, because in that presentation, when I was listing out the three aspects of a pluralistic system, the third one, which I minimized, was these things reveal the function of this feature in health. And I kind of just like, let's go talk about diseases. So yeah, that's a good point.
Well, actually, I refer to it frequently in any psychotherapy case with an anxious patient, because I point out that what anxiety is supposed to do is to evoke you to change something that's bothering you. And so if you're nervous because you haven't paid your taxes, well, pay your taxes, but what happens to people who are neurotic is they start worrying about things that are beyond their control. And at that point, it's obviously not the physiological basis of anxiety anymore. It's a dysfunction. And so that helps them, be able to sort of analyze these thoughts and see where the distortion is of the control fallacy in particular, right? And be able to challenge it. Now, I think that, it gets a little bit more challenging when you talk about like the true function of sadness, because that probably has to do more with the strength of the bond, interpersonal bonding. It may be a byproduct more than something that actually has a true function. It may be a side effect of the fact that we do bond to each other. I
always like the depressive realism conversation. I don't know how far we ought to take that or can take that. It might kind of just romanticizes some things, but.
So I think a functional mood system helps direct our behavior in general. If something makes you feel good, you do more of it. You feel bad, you do less of it.
Right.
I think that there's also like if your strategy isn't working, you need to change strategies. So you're sad in part, so you can disengage from the way that you've been doing it. At least that's the hope.
Yeah, the emotional stick as opposed to the emotional carrot.
We had another question. Pluralism, if the pluralism model were adopted by our field, what would that look like in a residency program curriculum as far as didactic topics or rotation experiences, or do you think that'd change anything?
Yeah, I mean, I think kind of mentioned this before, but I don't think it would change rotation or anything like that. I think the biggest change would be if, again, let's assume everything I just said is like legitimate and valid and scientifically backed up, which, I think it is, but being explicit in our didactics about the things that we know are diseases. And ideally we would have different research that would kind of support different approaches and be able to subtype. But if we don't have that, it would just be like, hey, like these are the things that are diseases. They are there. You can find them. If you find them, we should treat them. And then talking more about like the dimensions and like, we don't really, no one talks about like the MMPI and all that. And like, I don't know anything about it, but I just know that that's kind of what they use as the primary, what the dimensions all like revolved around. And like, so if we were to discuss that, really diving into that some more, so we could kind of see it in action, like where people's stress tolerance ends and symptoms start. But I don't think rotation would change anything. We just discuss it more.
In the history of the DSM, there have been conditions which were at one point felt to be psychiatric, that after they were determined to have genetic origins or other sort of structural origins, were reclassified as neurologic illnesses.
Yeah, I think that's and that's kind of why I use neurosyphilis for that one example, because like that was psych forever, and then it became neuro or infectious disease. And I think, I mean, I don't know, we may still find some other things, but I feel like what we're dealing with now is, it's sufficiently polygenic and not like, we're not saying this gene is bipolar, this gene schizophrenia. And I think because of that, we're probably stuck with what we've currently got. I don't see a whole lot transitioning over to neurology, but I wouldn't be surprised if there's some like weird subtypes of schizophrenia, like organic schizophrenia, that we actually find out are, autoimmune disease, stuff like that.
We are two specialties separated by the same organ.
Does anyone else have any other questions?
I
just
have,
wanted to,
sorry,
oh, go ahead, Jessica.
sorry, this presentation really picked my brain, so I have a lot of questions. But I guess one thing that really interests me, and this is kind of a common question, is I feel like this model would bring more focus, as far as the dimensionalism and the like life story, bring more focus to kind of aspects of mental health we sometimes kind of put on the back burner, such as social determinants of mental health, which was kind of the focus of the APA conference that we had. And I just kind of wanted to know your opinion if that would be the case, or would it not do that?
Yeah, I mean, I think that's a good point, because like we totally don't we pay attention to that in our research, but we don't pay attention to it in practice, except for like kind of giving it lip service. I personally do think that we would pay more attention to those things when we view it through an existential life story perspective. Like when we're actually trying to understand the human being, like it is impossible to ignore that stuff when you think about how can I understand this human being. But when we're framing it through like what are the sociologic and psychologic and biologic factors, I feel like it's too sterile, and we don't really pay that much attention to it, because we really don't. But also that begs the question, like, how's that going to change management? Obviously the answer to that is like, oh, more social services, this, that, and the other, but these are systems issues that are very difficult to manage. But yeah, I do think we'd pay more attention to that stuff if we had an existential perspective, personally.
And I just had a comment more than a question. I was just thrilled to hear that you mentioned this whole idea of, society using the mentally ill as a sort of scapegoat. I mean, between the consumer model and the DSM, we're pretty much incentivized to perpetuate that, which, I mean, the main problem, of course, is that we're putting the onus on the patient. It's the patient's problem, right? Rather than, something that no human being is really meant to have to go through. And it leads to an absolutely understandable reaction to it. In a lot of ways, that, the consumer model DSM combo is just masking, I think, a lot of the social inequities that our patients are faced with. That, I mean, that's the reason that they're suffering. And that's not something that we can easily treat or manage. But if we call it something that it isn't, then we're also not addressing what's actually going on and why they're actually suffering. So I was glad that, that's been a big part of the discussion today.
Yeah, I can't reiterate that enough. I feel like we know what's causing it, right? Like, it's certain people's existences kind of suck, and they are reacting accordingly. And sometimes they do eventually break off and have like such severe symptomatology that it's beyond the whatever, but it's not always the case, and there's not a lot we can do. But if we keep labeling it as something that is mental illness and is in our purview, then it just kind of perpetuates that, like, yes, there's nothing social that can be fixed here.
I'm doing this on my phone, so it's way more complicated than I was expecting. For this comment, which is mostly just you started the presentation was a little bit apprehensive because just from the last 4 years, you talk a lot about these ideas, and sometimes it's all over the place. But I'm really happy to see that you landed it, because not only after hearing you talk about a lot of these ideas in the last 4 years, seeing it crystallize in this way with some references for me to kind of explore, it's pretty exciting. And I think it's a good way for me to kind of the last time to hear you talk about all these things in person anyways, and to, take what I learned from you over these last 4 years and to continue it on in my own career. So I appreciate you presenting it, and appreciate you for these last 4 years.
Appreciate that, man.
Thank you so much, Stephen. That was brilliant, as usual, something we have come to get used to. And We appreciate your presentation. Thanks so much for coming.